This is a video in clinical medicine from the New England Journal of Medicine.
The purpose of this video is to teach physicians, nurses, and other medical providers how to use ultrasound guidance to place catheters in peripheral veins. Placement of a peripheral intravenous, or IV catheter, is indicated for the administration of intravenous fluids and medications. Placement of IV catheters is a fundamental skill that all professional healthcare providers should possess. IV access may be difficult because of obesity, IV drug abuse, the placement of multiple previous IV catheters, and other factors. In these situations, ultrasonography can facilitate IV catheter placement by allowing visualization of veins that are not apparent on physical examination. It is reasonable to use ultrasound guidance after 2 failed attempts at standard IV catheter placement, and it may be best to use ultrasound guidance immediately if there has been a history of difficulties with IV access in the patient. We will review the proper technique for standard IV catheter placement and then demonstrate ultrasound guidance. We will limit our discussion to the upper extremity veins, but the same techniques can be used to cannulate any peripheral vein. To find the best site for an IV catheter, it is important to know the venous anatomy. The metacarpal and dorsal veins on the hand are good sites for initial cannulation attempts. The cephalic vein is usually prominent on the anterior radial aspect of the forearm. The basilic vein on the ulnar side of the forearm is often neglected because of its posterior position, but is usually prominent and often larger than the cephalic vein. In the medial antecubital region, the basilic vein is medial and the cephalic vein is lateral. The median cubital vein runs diagonally through the antecubital fossa, connecting the cephalic and basilic veins. Antecubital vein cannulation is common in emergency situations, but not ideal for long-term IV therapy. Proximal to the antecubital region, the basilic and cephalic veins are deeper and often inaccessible without ultrasound guidance. In addition, the deep brachial veins run down the middle of the upper arm, adjacent to the brachial artery. Blind cannulation of these veins has a high complication rate, but they can be safely accessed with ultrasound guidance. Before starting the procedure, collect the necessary supplies. You will need a tourniquet, an antiseptic swab, an adhesive dressing, a needle and catheter, a Luer lock adapter, and a saline flush. The most common IV catheter consists of an inner needle and an outer catheter. Common sizes range from 24 gauge for newborns to 14 gauge for adult trauma patients. Most IV catheters are about an inch long, but longer catheters are available for cannulation of deeper peripheral veins. Potential complications of IV catheter placement include phlebitis, thrombosis, infection, ecchymosis, hematoma, and infiltration. Wash your hands and use universal precautions. Apply the tourniquet. Palpate or visualize the vein. Veins should be soft, elastic, and resilient, and should be pulseless. Clean the skin with the antiseptic swab. Stabilize the vein with the fingertips of your non-dominant hand. Hold the needle with your dominant hand between your thumb and index finger. Make sure the bevel is pointed up. The needle approach should be along the course of the vein at an angle of 10 to 30 degrees to the patient's skin. Puncture the skin and then the vein with a quick forward motion so the needle tip penetrates the wall of the vein instead of just pushing it aside. When the needle tip enters the vein, there will be a flash of blood into the catheter. Decrease the angle of the needle and advance 1 to 2 millimeters further to ensure that the entire needle tip and the tip of the catheter are fully within the vessel. While holding the needle still, slide the catheter into the vein. Apply firm pressure to the vessel proximal to the tip of the catheter. Remove the needle and place it into a sharps container. Remove the tourniquet. Place the Luer lock adapter on the end of the catheter. Anchor the catheter, adapter, and connection tubing to the skin using adhesive dressing. Flush the catheter with sterile saline. The flush should flow smoothly into the catheter. If there is resistance, the catheter may be kinked, occluded, or outside the vein. Look for signs of extravasation, such as pain, swelling, or blanching. Providers who are proficient at standard IV catheter placement will find it relatively easy to learn ultrasound-guided techniques. Novices need to understand a few basic ultrasound concepts. Ultrasound images are created by reflections of sound waves, so denser structures appear bright and fluid-filled structures appear dark. Changing the gain changes the brightness of all structures on the ultrasound image. Gain should be adjusted so vessels appear black and the surrounding soft tissue appears gray. The ultrasound image plane is several millimeters long in the longitudinal axis and only about 1 millimeter wide in the short axis. By convention, the top of the ultrasound image represents the skin surface and deeper structures are at the bottom of the image. There are centimeter marks on the sides of all ultrasound monitors, so it is always easy to determine the depth. Depth should be adjusted so that the target vessel is in the center of the image. Left-right orientation should also be easy because the symbol on the left side of the ultrasound image correlates with the indicator mark on the transducer. A linear array transducer with a frequency of 5 to 13 MHz is usually used for ultrasound-guided vascular access. Short linear transducers are made specifically for ultrasound-guided procedures. It's best to place the arm in a horizontal position so the ultrasound images and needle movements are in the vertical plane. Elevate the bed or sit down so that you are not bending or stooping, but working with your hands comfortably in front of you. Place the monitor so you don't need to turn your head or look over your shoulder to see the ultrasound images. There are two commonly used techniques for ultrasound-guided vascular access, the transverse technique and the longitudinal or in-plane technique. Transverse or longitudinal describes the orientation of the ultrasound plane with respect to the vein and the needle. In the transverse technique, the ultrasound plane is transverse to the vein and the needle, so the vein is circular and the needle is a single bright dot. With the longitudinal technique, the long axis of the vein and needle are in line with the ultrasound plane, so the vein appears as a tubular structure and the entire needle is visualized. The transverse technique gives less information, but is easier to learn and is recommended for novices. The longitudinal technique is more difficult to learn, but is preferred by many experienced providers. We will demonstrate these techniques and explain why it is best to learn both. Regardless of which technique is used during the procedure, start by evaluating the anatomy using the transverse approach. Transverse imaging provides a cross-sectional view of the anatomy and allows simultaneous visualization of veins, arteries, and other structures. It is important to align the transducer so that its left and right sides correlate with the left and right sides of the image on the monitor. Aim the transducer indicator in the same direction as the indicator symbol on the display, or simply touch one side of the transducer and look for movement on the monitor, then align the transducer as needed. In transverse images, the veins and arteries appear as circular structures. Veins are thin-walled and compressible. Arteries have thicker walls, are not compressible, and have visible pulsations. The easiest way to differentiate veins from arteries and ensure vessel patency is by simple compression. Using Doppler ultrasound is more difficult and unnecessary. Look for more distal veins first and move proximally as needed. The antecubital veins may be the best option in an emergency. In the upper arm, the basilic vein is often the best choice because it is usually large and does not have an accompanying artery. In the proximal upper arm, the basilic vein is fairly close to the brachial artery and the ulnar nerve, but distally it moves away from those structures. The cephalic vein is a good choice if it is large enough, because it is more superficial and has no accompanying artery or nerve. Cannulation of the deep brachial veins is possible with ultrasound guidance, but caution should be used because of the proximity to the brachial artery and the median nerve. Consider the following guidelines when choosing a site for ultrasound-guided IV catheter placement. Choosing a vein with a larger diameter improves the likelihood of success. Standard IV catheters are 3.2 centimeters long and usually adequate for cannulating veins less than 1 centimeter deep. Double-length catheters are available and adequate for veins up to 2 centimeters deep. Specialized equipment may be needed for veins deeper than 2 centimeters. Placing a peripheral IV does not require the operator to wear sterile gloves and a gown. However, hand washing, clean gloves, and universal precautions are indicated. Clean the ultrasound transducer thoroughly with a germicidal solution. Apply the tourniquet. Apply gel or surgical lubricant. Identify the target vein. Note the depth of the anterior wall of the vein. Clean the skin with an antiseptic swab. Insert the needle through the skin at an angle of about 45 degrees and adjust the trajectory as needed. Advance the needle toward the vein and look for the needle tip to appear on the ultrasound image. The needle tip will appear as a single bright dot with posterior shadowing or a repeating artifact. Follow the needle tip as you advance it by fanning or tilting the transducer in the direction that the needle is traveling. If you can't identify the needle tip, look for compression and movement of the adjacent soft tissue and tenting of the anterior wall of the vein. Subtly bouncing or vibrating the needle will cause movement of the soft tissue adjacent to the needle and may help you identify the position of the needle tip. Be careful not to advance the needle too deeply. Look for indentation of the anterior wall as the needle tip enters the vein. Watch for blood return. Decrease the angle of the needle and advance it 1 to 2 millimeters further to make sure the entire needle tip and the tip of the catheter are inside the vein. Hold the needle still and advance the catheter into the vein. Remove the needle and place it into a sharps container. Remove the tourniquet. Anchor and flush the catheter as previously demonstrated. The transverse approach is best for less experienced providers and when there is patient movement during the procedure, because it does not require perfect alignment of the transducer, the vein, and the needle. It also allows the operator to visualize the structures adjacent to the vein during the entire procedure. The problem with the transverse approach is that it can be difficult to visualize the needle tip and the ultrasound image can be deceiving. The needle may appear to be in the vein or more superficial when the tip is actually much deeper. The longitudinal or in-plane approach provides good visualization of the needle tip and vein, but it does not allow simultaneous visualization of surrounding structures, so always evaluate the anatomy transversely before attempting the longitudinal technique. Apply the tourniquet. Apply gel or surgical lubricant. Visualize the vein transversely and use simple compression to differentiate arteries from veins. Rotate the transducer 90 degrees and visualize the vein longitudinally. The transducer indicator can be aimed proximally or distally, depending on personal preference. However, it is crucial to know which side of the image represents the distal vein, because that is where the needle will enter the image. Hold the transducer with your thumb, index finger, and middle finger. Place your other fingers on the patient's skin so you can hold the transducer completely motionless during the procedure. Use an antiseptic swab. Carefully align the needle before insertion so that the trajectory will be precisely within the ultrasound plane. Puncture the skin just distal to the transducer. You should be able to clearly visualize the needle tip during the entire procedure, but this requires perfect alignment of the needle with the ultrasound plane. If you can't see the needle, it is lateral to the ultrasound plane. Back up and redirect the needle as necessary. Do not advance the needle unless you can see the tip. Visualize the needle tip inside the vein. Hold the needle still, advance the catheter, and watch it slide into the vein. Remove the needle and place it into a sharps container. Remove the tourniquet. Anchor and flush the catheter as demonstrated previously. Ultrasound guidance facilitates peripheral IV catheter placement when standard techniques fail. Learning ultrasound-guided techniques is relatively simple, especially for providers who are proficient at standard IV catheter placement. Smaller linear transducers and long IV catheters are ideal for ultrasound-guided IV catheter placement.